Hello, everyone. It is a great pleasure to see you once again. This is the second edition of our PCR webinars on the road series. And today we travel virtually to New York City, New York, to Montefiore Hospital to visit our friend, Dr. Azim Latib. And this webinar will be hosted by myself and by my friend and colleague, Chiara De Piace from Naples, Italy. So as you have already heard in the first edition, the concept of this webinar is the following, and you can see it on this slide. Basically, we try to specify the problems encountered in patients in our cath lab and focus on a single patient. Our intention is to explore the variables and to explore the determinants of the long-term prognosis when treating our patients in the cath lab. We focus on a single patient, on our patient, on your patient, today on Dr. Azim Latib's patient in the Montefiore Hospital in New York, and we see how he applies general principles and how he also applies procedural factors and clinical factors of this single patient into his decision-making to make the best decision for the patient. Today's topic is small vessel disease, and I would like to ask Chiara to explain to us what are the objectives today.
It's really a pleasure to be with you today and with Dr. Azim. And next slide, please. We are going to have an overview in order to learn how to assess patients with a diffuse disease but small vessel coronary disease. We can discuss the different options that we have to treat this type of patients, and we will learn how to apply some of the tools that we have, such as the drug-coated balloon that are particularly useful in a small vessel disease. So please, Dr. Latib, if you would just describe what do you do in your cath lab, in your clinical practice, and just present the place you work in.
Good afternoon, everybody, and thank you for joining us here at the Montefiore Cath Lab in the Bronx in New York. We have, quite a large health system, the Montefiore Health System, which is about 10 hospitals. 5 of those hospitals have cath labs, and we all one large health system. So I'm the director at 2 of those cath labs here in the Bronx, one in the east part of the Bronx, one in the west. We do over 6,000 procedures a year, over 2,000 PCIs, and probably over 300 structural procedures. And it's a very interesting patient group that we serve in the Bronx. It's a very diverse patient group with a lot of African Americans, Hispanics. It's also a patient group with a lot of coronary disease. So whereas in many centers, maybe the number of patients undergoing PCI are decreasing, in our center, it's actually increasing every year. We see a lot of patients, probably 75% of our patients are with acute coronary syndromes, 25% with stable angina. But we also see patients with a lot of very advanced coronary disease. So a lot of risk factors, a lot of diabetes in probably 40% of our patients, and sometimes even up to 50%. A lot of hyperlipidemia, sometimes untreated hyperlipidemia, severe hypertension, still a lot of smokers, unfortunately, in this community too, and then a lot of obesity. So basically, it's the perfect melting pot for really advanced and severe coronary disease, especially diffuse coronary disease, which is what we're discussing today.
Thank you very much, Dr. Latib. Could you share with us one of your cases to start with?
Yeah, absolutely. Let me take you through, an interesting case. This is a 66-year-old male who's known with hypertension. He's dyslipidemic, type 2 diabetes, and he presented to us with worsening effort-induced angina and had a positive SPECT scan. Now, one of the things, I've learned working in the Bronx, it's before doing the coronary angiogram, it's really important to try and control these patients' risk factors. So we spend a lot of time, optimizing their anti-lipid therapy, their HbA1cs before bringing them to the cath lab. And as interventional cardiologists, we sometimes forget that we're also cardiologists and doctors. And so that's an important part of what we do. So here's the angiogram of this patient. He essentially had single vessel disease, but really aggressive single vessel disease. So here you see this very diffuse long segment of LAD disease starting at the proximal vessel, involving a bifurcation with a large diagonal, and then extending distal to that diagonal. So it's the kind of disease, when you see it as an interventionist, it kind of makes you stop to pause a little bit. It's not the kind of case where you just run in to start sticking stents into this patient, because if you look, this patient is going to end up with a lot of stents. If you decide to treat this percutaneously, there's potentially this patient ends up with close to 80 millimeters of stent, what we would call a full metal jacket. And what I hope by the end of this session to convince you, Dejan and Chiara, and some of our listeners, is that maybe there are other ways of treating diffuse disease, especially, in an important vessel like the LAD. So with this kind of patient, we stop. We'll not do ad hoc PCI. We'll stop here to really think about and discuss the options with the patients. Now, what could be the options? The options could be either medical therapy, but that wasn't working for this patient. He was already on 2 anti-anginals, plus we controlled his lipids and his diabetes. It's PCI, and how are we going to perform that PCI? If we do decide to perform that PCI, are we going to do a full metal jacket? Are there other more novel, newer approaches to prevent us from putting too much stent in? And third, whether this would be a good case for bypass surgery. So Dejan, Chiara, what are your thoughts looking at this?
Well, I think that the most important thing is to choose how to treat this patient, because he's symptomatic. So we have to do something, but we have even considered the diabetes, that it's a predictor of worse outcome, above all with PCI. So if we have to choose PCI, we have to plan and adopt PCI with all the tools that we have, even because we have an LAD, a bifurcation, and a diffuse disease that maybe will be a problem even for the surgeon. So in this case, we usually ask to the surgeon suggestion, and then we manage the best way we can treat, if we choose for a PCI, the PCI, because sometimes surgeons refuse this kind of patients. I don't know, Dejan, in your cath lab, which is the routine.
Yeah, roughly the same. We would probably go to the heart team with this patient, but I think 2 important variables need to be discussed here, and I would like to hear the opinion of Dr. Lateeb on those 2. First is, if we have a diabetic patient with a diffuse disease that extends from distal LAD into what seems to me at least the ostial LAD and even the left main. So basically you have a left main with a diffuse LAD disease and diabetes. Is this 100% surgery? And how do you see that? And the second is, since we actually want to achieve complete revascularization, there are mounting data actually that the complete revascularization is something which provides long-term benefit to our patients. So the question is, how can we be sure that by percutaneous methods in such a patient that has a diffuse disease extending into what seems to be very small diameter distal LAD, how can it be granted and achieved by PCI? So diabetic patients, is it always a surgical domain? And secondly, what is the role of small vessel disease in complete revascularization?
Yeah. Those are both great comments, Chiara and Dejan. It's something I struggle with all the time. Let's start with diabetes, right? And your question is, seems to be often a feeling from some of our colleagues that if a patient is diabetic, diabetes equals bypass surgery. Now, I don't believe that's completely true all the time. And I think what's more important is being sure that we can fully revascularize that patient, whether that's percutaneously or surgically, but that also, and I keep saying this because I see in the Bronx patients who come to me, like the one I showed you with an HbA1c of 12, right? an important part of this is also medical management. Now, when you remember, when we looked at, the syntax studies, okay, diabetes is as impactful a negative prognostic factor, both for PCI as well as for surgery. So, I mean, I think we have to move a little bit away from saying that every diabetic is equal to cabbage. I think it's more looking, into the details of the patient, the anatomy, the vascular territory, and how can we fully revascularize that patient. So let's get back to my patient, right? So like you mentioned, my patient has this diffuse disease extending almost from the LAD ostium to distal to a large diagonal. So if we were to consider bypass surgery in this patient, I would have two concerns. Like you said, there's probably if I'm going to treat this with PCI, I'm probably going to extend from the left main all the way till distal LAD. So potentially a full metal jacket, which we all believe is not good for our patients if we put in more than 60 millimeters of stent. But the surgeon, what is he going to do? He's probably only going to stick a bypass graft on the LAD, but on the very distal part of the LAD. Right. And I think in these kind of cases, it's always very important to know your own heart team. And that's why I like what you guys are doing with this series, is you're going around the world speaking to different heart teams and different institutions, because every institution functions differently. So in my institution, we have very good surgeons, and we have a very good hybrid revascularization approach here. So I have a surgeon I work with who if I have multivessel disease and I have a LAD that's a good target for a bypass, he'll do a robotic lima for me, and then I will revascularize the other vessels. In this patient, though, if you look at it, this patient is not a great candidate for robotic lima, because I think you're going to end up very distal on the LAD. But also you have to probably graft also the diagonal, because that diagonal is pretty large, for me at least, and for us as interventionists. And I'm not sure he's going to be able to do that. So my concern in this patient was, if he gets just one graft, a lima to the distal LAD, it leaves a large territory not well revascularized, because it's only the distal territory revascularized.
Thank you for that. And let us now move on and wrap up this discussion with two slides, basically summarizing what we have said. So in diabetic patients, we should aim for complete revascularization, and we should try to do that with PCI. And I would here like to mention a sub-analysis, basically a 10-year mortality data from the syntax trial, which showed that there are comparable mortality results with either PCR or CABG in 3-vessel disease or left main patients if we achieve complete revascularizations. And here on this slide, you see 3 main reasons for not achieving complete revascularization. In this very patient, we have both bifurcations, a large diagonal bifurcation, and most likely distal left main, because most probably the stent will have to go into the distal left main part. And we have the small vessel and diffuse disease. So 2 reasons for not completely revascularizing are there. So we need to take care of that. And on the next slide, you see what Dr. Lateeb was referring to. This would happen if the surgeon would have done it. It is far too distal. It may be not enough of a myocardial territory supplied by this graft. And as you can see, the dilemma is, do we treat the culprit lesions, or are we thinking about the myocardial territory? Because if you think about putting 80 millimeters, 8 centimeters of stent, that is, of course, something which is related to adverse events in the follow-up. But if you think of supplying complete revascularization to this whole myocardium, then treating this with percutaneously may be the better option in this very patient. Before we go to the next segment, we have from the chat box several questions, and one is directly referring to you, Dr. Lateeb, regarding to the syntax score. So do you use a syntax score to guide your decision-making in a patient like this?
Yeah, that's a great question. I do use the syntax score. I do, though, try to use a more functional syntax score, right? So I will calculate the syntax score based on all the vessels I see. When I then, and evaluating the case, I'll also perform often FFR, so I can understand how many of those lesions are actually significant. Because remember, Syntax score is purely anatomical. It doesn't tell us about functional significance, right? So you could have a vessel, a marginal vessel that is 2.5 millimeters in diameter, but with a very small territory of distribution where it gets a score on syntax, but when you actually assess it functionally, it's not significant. Similarly, you may get a CTO of a right coronary artery that is a codominant right coronary artery with not a large territory of distribution, where revascularizing that CTO is not going to impact the patient, and even a surgeon would not stick a bypass on it. So yes, I do, but then I try and take it one step further, and I try and use it in a functional way about is this an area that's either FFR or IFR positive, or is it an area that would give the patient benefit by treating it? And I kind of then have a more rational syntax score as well. And then finally, I also think about how many stents and what stent length I would need in order to be able to treat a patient, right? And the longer that is, the more reluctant am I then to say that patient is a good candidate for PCI.
So thank you. You obviously decided for percutaneous revascularization here. What is it that you did next?
Right. So, I mean, here we had long diffuse disease, okay? And part of my strategy up front was I was going to try and limit the amount of stent length, okay? And I was going to try and use a hybrid approach of using drug-eluting stents proximally and drug-coated balloons distally. So I went into the case with that at the back of my mind, is that as much as possible, I wanted to limit the amount of stent length. So I put a wire down the LAD. If we just stay back on the previous slide, I then started from distal to proximal, and I pre-dilated with non-compliant balloons. It's my practice to almost always use non-compliant balloons for pre-dilatation, unless I have difficulty passing a non-compliant balloon. I will use a semi-compliant balloon. And that's where I start. I think and we can talk about why that may be better. Next slide. So I started distally at 2.5, then I went up to 3.0 in the mid LAD, and then I went up to 3.5 millimeters in the proximal LAD. And what you notice is that I'm not doing very gentle pre-dilatation. I'm doing pre-dilatation that's almost one-to-one with the vessel size and with the stent that I'm trying to implant. Why am I doing that? I'm doing that because I really want to prepare this lesion well. Okay. In the past, we maybe were a little bit scared, and some people still are, to do one-to-one pre-dilatation. Why are we concerned? We're concerned maybe we'll cause dissections, but I don't think we should be concerned about that. If you have a distal wire and you cause a dissection, I was taught by some of the old masters of interventional cardiology that causing a dissection is good lesion preparation. It's how we make sure that lesion is ready for a stent. And as long as you then have stents in your cath lab, you can deal with most dissections, okay? So I like to go one-to-one. I start with non-compliant balloons. And if my non-compliant balloon doesn't fully expand, I will then consider other technologies and other devices. So here you see this lesion preparation starting from distal to proximal. What do you think, Chiara? Is that what you do in your cath lab?
Indeed, thank you very much for your explanation, because I must confess that above all, young interventional cardiologists are scared by non-compliance balloon. And indeed, in my practice, I always tend to use a semi-compliant balloon because I feel comfortable. Indeed, we have to consider that we can have dissection with any balloon, that maybe after your explanation with non-compliant balloon, we can moderate and control better our type of balloon. And it was amazing at the beginning because non-compliance, I thought to myself, wow, very aggressive. Indeed, I think that you really managed your strategy. And in my practice, if a semi-compliant pass, okay. If I want better, I use the non-compliant balloon, but I've never thought to myself, if direct non-compliant doesn't pass, I will use more. So it's really educational for me. Thank you. What about Dejan?
And yes, yes. Well, I agree, and I try to use the non-compliant balloons whenever they can pass, as Azim said, provided that, of course, with the semi-compliant balloons, you always run the danger of not being in control of what you do, because the semi-compliant balloons do not always inflate uniformly. So basically, you can be applying a pressure to a lesion that you basically want to apply pressure to. And on the other side of the balloon, you can have more inflation that you actually wanted and have a damage to the vessel wall that you did not want. But Chiara, could you show us, in principle, summarizing what we just have seen, what is the difference between the semi-compliant and the non-compliant balloons?
Well, as you said, it's all in the type of balloon that we are inflating, because we can see that at the same atmosphere, non-compliant and semi-compliant balloon respond differently. As you told us, the control of the inflating is very important, even because, as Dr. Latif told us, the 1-to-1 ratio is the good way to prepare, but not more, maybe, because yes, we can have a dissection, but we want the dissection where we pre-dilate. So if we go to the next slide, we can see that above all, in a diffuse disease, we have multiple plaques, so multiple points where we want to inflate our balloon, but at the proximal and distal edge, we have some good vessel that maybe we don't want to touch. So if we can control our inflation, we can reduce maybe the risk of enlarged dissection or the dissection in the point of the wall that we really don't want.
Okay, thank you for this brief explanation. Dr. Latif, could you continue? Did you put 8 centimeters of stent in this patient? Was it what you decided at the end?
Well, let me just make a final comment on what Chiara showed, because I think this is a great learning point for the audience and for young interventionists, right? It's so important what we just said now, and it's a change of mindset, right? Because I think a lot of young interventionists are taught to start with semi-compliant balloons, but I think your picture shows very well that when you use non-compliant balloons, because you control actually the size of the balloon and how much pressure you're exerting, you get a better pre-dilatation. 2 other pieces of advice I would have for you when you're doing non-compliant balloon dilatation for diffuse disease. I don't know if you noticed from my pre-dilatation, the balloons were not 12 millimeter balloons. They were longer balloons, okay? So use longer balloons, use 20 millimeter balloons when you're doing diffuse disease. And the last thing is do long inflations. So also, I see many young interventionists, even when I'm training them here, when I tell them to do a pre-dilatation, they go up. I say, I'm at 12, and they go negative, okay? When you're doing diffuse disease especially, you need to go up, okay? Get to a pressure where you see good balloon inflation and leave it there for 30, 40 seconds even. I sometimes even do a minute of pre-dilatation with a balloon. My patients are okay. I watch the ECG. I watch the patient. If the patient's not having chest pain, if the ECG looks okay, I leave the balloon up. And that's another really important trick just for, for young interventionists when you're thinking about diffuse disease. So we really, after doing the pre-dilatation, the vessel looked okay, but I was uncomfortable about the proximal vessel. So what we decided was that we would stent just the proximal vessel and try and do drug-coated balloon in the distal vessel. So we, as you see here, we put a 3.5 by 38 stent, extending really from the ostium to the mid-LAD, and then another short stent distal to that and overlap, the 3.0 by 16. So, just over 40 millimeters of stent. And then this is what the result looked like. The distal vessel is still diseased. And you see a result where excuse me for saying this, but for young interventionists like yourself, you often say, but that's not good. I want a beautiful result. I want an aesthetically beautiful result, right? And so for many young interventionists that say, no, I need another long stent there, at least another 30, 38 millimeter stent. So what I actually did there was I used a drug-coated balloon, a 2.5 by 30 millimeter drug-coated balloon. And the reason I thought this was a good lesion for a drug-coated balloon at this stage was, if you look at the angiogram, there's no flow-limiting dissection, Okay, I'm sure if you do imaging, you will see small type A, type B dissections on imaging, but on angiography, there's no flow limiting dissection. And also notice that we did good lesion preparation. Even though there is still some residual stenosis, I would call that residual stenosis probably 30% or less. Okay, and to me, those are the two variables that I look at to say, this is a good case for drug-coated balloon. What's the percentage residual stenosis? And is there flow limiting dissection?
Okay, but we have some questions in the chat box related specifically to drug-coated balloons. And now all three of us can discuss it because I think it's an important point. You limited the length of the stents, and we all know that the length of the stents, according to the studies and the data available, more than 6 centimeters, more than 60 millimeters, are associated with poor outcomes and are sign of the complexity of PCI. So you did limit the length of the stents by using the DCB. Now the question is, one of the questions in the chat box is, what sizes are there? From what I know, you can go from 1.5 millimeters up to in diameter up to 40 millimeters in length. And this is exactly what we have been talking about. This is exactly for the case that you just shown. So for the distal parts of the LAD, for example, where you need a long balloon, a long drug delivery surface, and a diameter that is as small as it can get. So what is it that you use in your everyday practice today? Or do you use anything? Or what is your position on that?
Yeah. So number one, I agree with you. I think, the great thing about drug-coated balloons, they're from small diameters to large diameters. Another probably trick I would say is when I had availability of drug-coated balloons, I only kept 20 and 30 millimeter balloons. I only kept the long balloons. I didn't keep 12 millimeters, 15 millimeters, 18 millimeters. I kept two sizes essentially in my cath lab. The longest they had, if there was 30 or 40, and one size shorter. Those are the only lengths you need. Okay, don't keep 10 different lengths. You need different diameters, but don't keep 10 different lengths. And the reason being is always you want to treat large segments with a drug-coated balloon. It's really safe. Okay, and we should talk, a little bit later when I show you the follow-up result on this, on the risk of acute occlusion and how you manage dissections. Okay, but as far as which drug-coated balloons I use, so I got to tell you, the sad thing is I live in New York and I work in New York, which is, we have many advanced technologies, but we don't have drug-coated balloons here in the United States yet, unless in clinical studies. So there are a whole lot of clinical studies that have started this year in restenosis and diffuse and de novo disease, small vessel disease. So we should have drug-coated balloons in the near future. But when I worked in Europe, and I still do cases in Europe, there's a lot of drug-coated balloons available. In my experience, I mostly use the paclitaxel ones in the past. And there are a number of good paclitaxel drug-coated balloons. There's the new one from Medtronic, Prevail. There's the Boston Agent balloon. There's the Sequent Please. They're all really great balloons. I think also now we're seeing a surge of new sirolimus drug-coated balloons. And there's one, the Magic Touch from Concept Medical, and another one from a company called MedAlliance called Solution. So we're also going to see now a lot of comparative studies comparing sirolimus and paclitaxel drug-coated balloons. But the one thing you should never assume with drug-coated balloons, and we learned this the hard way, because at one stage there were 12 drug-coated balloons in Europe. It's not a class effect. Okay, you really have to look at two things when you look at three things when you look at a drug-coated balloon. Number one, what's the excipient? So the excipient is what the company uses to attach the drug to the balloon so that the drug stays on the balloon when you're pushing it up and it's got contact with the blood. Okay, so it doesn't wash away. And it's also what allows it to then transfer the drug to the wall. Okay. Number two, you got to look at the drug and the dose. And then number three, how the drug is actually put on the balloon and how the balloon is wrapped. Because that's also, there's a lot of, important steps in how you coat the balloon. And then the balloons are wrapped in a specific way so they can hide a lot of the drug. Because no matter what any company tells you, Okay. Once you take a drug-coated balloon and you put it in water or you put it in blood, you're losing some of your drug. Okay. Always, no matter what anybody says, you're always going to lose some of your drug. The question is, how much of your drug are you going to lose?
Yeah, I think this is a very, very important point that we need to stress. So there is no class effect. There appears not to be. And I think those three factors that you mentioned, how the drug is basically delivered, what I think we should know is that there is a certain amount of drug on the balloon. And there are three ways to lose the drug. Either it goes down, it's washed off, it's washed downstream, distal downstream in the coronary artery. The second is you pull it out with the balloon because some of the drug stays on the balloon. And the third is that you can make a sort of a mistake when you inflate the balloon and maybe post-dilate afterwards, because there will be some remnants. There is not going to be an instantaneous absorption of the drug into the endothelium. So I think combined all these things together, I think it is important to know how to use these balloons. It is not just a balloon to be inflated. It is also very much a balloon that needs a sort of a training in order that you understand what the drug is, what kind of a drug there is, and what kind of a carrier there is, so that you can know what to expect when you inflate the balloon and keep it for 30 to 60 seconds, which is usually the case. But there is a question in the chat box, which I think I would ask both you, Chiara, and Dr. Latib, and it pertains to when would you choose a drug-coated balloon opposite to or over a drug-eluting stent in terms of vessel diameter. So this should be understood differently from what we have been talking about. So in the case that Dr. Latib just showed, he used the drug-coating balloon to reduce the stent length. And he used a 2.5 diameter instead of a 2.5 millimeter stent. The question that I just asked from the chat box, and it's Dr. Sajan asking this question, he basically asked about the vessel diameter. So in what type of small vessel coronaries do you use a DCB over DS? Is there a cutoff in your practice? Chiara and then Dr. Latif, please.
Okay, in my practice, there is really no diameter limiting the choose of the stenting, but it's more the section of the vessel where is the lesion that I want to treat, if more distal or not, and absolutely the quantity of stent I have already put in this same vessel. So in this case, probably I would have told myself, okay, I put 60 millimeters, okay, but I still have a medium LAD that it's not really good for the angiographic outcome. So I would probably have chosen a DCB just in order to not put other stent, and even just to open a little bit more the LAD at the medium level. But it's not a diameter, because we know that we can use some 2 millimeter stent and we can have good results from some registries. But in this case, it's a question of strategy and quantity of stent for this patient. I think this is the real point, as Dr. Latif told us. But please just explain us as you chose, even because if there is a dissection of type C, where we are obliged to put stents. So
yeah, absolutely. I think it's a great question, and I agree with your comments, Chiara. I kind of look at drug-coated balloons as devices I use in lesions where I would prefer not to implant a stent. Okay, so this kind of case where I showed you, where there's diffuse disease and there's diffuse small vessel disease, I'm trying to minimize the amount of stent implantation. I prefer drug-coated balloon, right? And I really like it in diffuse small vessel disease, I have to say. And I define diffuse small vessel disease as vessel diameters less than 2.75 millimeters. But I will also at times use it in a 3035 vessel. So, another place where I like using drug-coated balloons is sometimes when I have a patient who can't undergo surgery and needs left main PCI, and I'm going for a provisional approach, but I don't like the circumflex ostium, and I hate putting stents in the circumflex ostium, I'll maybe use a drug-coated balloon to treat the circumflex ostium. And it may be 3 or 3.5 millimeters. So I really try and use it in places where I think stents are not going to work well. I think for those of you who are starting to use it or not using it a lot in your practice, okay, I think that's where you should try and use it. Try and use it in small vessels, diffuse disease, some side branch osteums, obviously restenosis. I, however, predict that we're going to see more drug-coated balloon usage in the coming years. So I saw some data already, and this confirms what was my practice, is that, in my practice when I was in Italy, I used drug-coated balloons in 20% of my PCIs. That's quite a lot, 1 in 5 PCIs. And there's some data from Europe now, speaking to some of the companies, to Medtronic in Boston, where they're seeing an increased usage of drug-coated balloons. Part of it, I think, Tejan and Chiara, is, remember BVS, okay? And we all were so excited about BVS and this concept of leaving nothing behind, okay? Maybe drug-coated balloons can fill that void, okay? Because they may be able to allow us to leave nothing behind, okay? But including not this thick scaffold that could dismantle with time and then cause late events, right? So I think, even though BVS are not really being used anymore or minimally available, they taught us a few really important things. They made us all understand, I think many of us, that maybe we put too much stents into patients, too much metal stents, and maybe we can decrease those metal stents. They also taught us, I think, how to do better PCI, because one of the things we realized from BVS that even when we did the randomized studies, because of learning to do better pre-dilatation, using imaging and better post-dilatation, even our metal stents, the outcomes were better than ever before, all right? And then I think the third thing they taught us is that if we can leave a vessel without a metallic cage, we allow that vessel maybe to remodel in the future and to get bigger in the future.
Okay, so thank you for this insight. I think we move on with the message that I think was clear from both of you said, and this is a specific question. So we do not use DCBs, at least in our experience, only because of a small diameter. We may use it more also in a larger diameter vessels for specific reasons. Now, what is important to now conclude here is that we are well aware of the concept that we have talked about. So we need a balloon that is sized probably 1-to-1 so that we touch the wall so that we can deliver the drug. We need to be aware of the drug release and absorption kinetics of a specific DCB that we use. Then this is what we are left with after we pull out the balloon, the drug that should enter the endothelium. Now, lesion preparation was another issue with the DCB, and we have seen how extensive lesion preparation was. The reason is this: if we do not do pre-dilatation, we are going to be just putting a layer of a drug on stenosis that has not been solved, that has not been corrected. And in green, you see how it looks like with the pre-dilatation. And finally, and this is one of the questions from the chat box, it refers to a question from the chat box as well from Dr. Mellon: should we post-dilate after DCB? And I think that this may not be the best idea. One of the reasons is shown here. So if we put a DCB into a coronary artery that we did not pre-dilate, and we get the result on the left-hand side, and then we try to post-dilate, what we may end up with on the right-hand side is the disruption of the drug kinetics that we are actually expecting. So we may first disrupt the way the drugs are getting into the cells. We can cause a slow flow because we increase the wash-off effect, and we can finally also cause additional dissections that may then warrant additional stenting. So this is basically, these are the problems. So this is a summary from the consensus document that Dr. Latif was part of, and I'm just going to briefly reiterate what he also said in the discussion that we had previously. So basically, after pre-dilatation, after lesion preparation, for that you can also use cutting balloons and scoring balloons, and this was one of the questions in the chat box as well. Yes, you can use them, of course, but see if we have no dissection that is flow limiting, and that we have no residual stenosis that is above 30%, or that we have no FFR significant residual stenosis. If those criteria are fulfilled, you can actually proceed with the DCB only strategy according to this algorithm from 2020 from the International Consensus Group on DCBs. Now, I would like to ask Dr. Latif to show to us what happens to these vessels afterwards, because there was a repeatedly question in the chat box. Why not just use POBA? Why should I want to use a DCB? Why not use POBA in small vessels? So could you explain to us what is one of the arguments for using DCB over POBA?
Yeah, absolutely. So I think, in the old days, we did use POBA because we didn't have drug-coated balloons. And when you do use POBA, I think the risk of having restenosis is higher. And what we've also seen with DCB is that by delivering drug, we actually see more positive remodeling. So there's now a number of studies, probably about 3 studies, angiographic studies, that have looked at patients, their final angiography, the QCA at the end of the procedure, and then at follow-up. And all of them have consistently shown an increase in vessel diameter. We also, we did a randomized control study called BELLO that we published in JACC in small vessel disease. And even in that study, we showed that there was negative late loss in diffuse disease, in small vessel disease, which means that the vessels got bigger. We've not seen that as consistently with just a normal balloon. I do believe, we do get a better result. So yeah, let's just check at the end of the procedure. Okay, I'm sorry, at the beginning of the procedure, see the diffuse disease. Okay, we then, at the end of the procedure, you see our 2 stents plus the drug-coated balloon with the result that some may say, well, I can get a better result with a stent, but look at the follow-up result. That's 4 months later. And at follow-up, the result looks fantastic, right? There is really positive remodeling. The vessel looks bigger. The vessel has healed. And I think we have a better outcome. Now, this is one case. And someone may say, but Dr. Latif, that's an anecdotal case. No, we see this, on a number of cases. We've now, do this routinely as approach. And I think in the future, in a case like this, you may even be able to decrease stent length even further. Maybe just spot stenting the very proximal vessel where there's maybe some dissection and leaving the rest with drug-coated balloons.
Okay.
An important part, I just want to say one last thing, an important part of the strategy, which we didn't discuss, and maybe we can discuss at this time, Dejan, is also the use of imaging and FFR and physiology in these kind of diffuse disease cases, right? And I don't know what your thoughts are, Dejan and Chiara, but I think they play a really important role.
Yes, definitely. One concern that I would have is passing the wire distally enough to get both the good intracoronary physiology measurement, but also a good imaging picture, especially with the OCT, where you really need some distal segment, some decently long distal segment in order to have a good visual. So we have 15 minutes more, and I would like to go to the second case very soon, which is also very interesting. And I would like to ask Dr. Latif to walk us through that second case. This is the final image from the first case. So basically, if we go back to our standard procedure, we want to delineate which factors are going to determine prognosis in a given patient. In this patient with diabetes and diffuse coronary artery disease, we cannot do anything about age or frailty. We cannot do anything about LV function at this time. But what we can do about is decide between PCI and CABG. And this decision will have some weight on the prognosis. And we can also decide on the complete percutaneous revascularization. And we can also try to use DCBs, as it was shown here, to at least reduce the stent length, which we know is determinant of ischemic events, more specifically stent-related events. So this is a brief summary of what we have seen today. So now I would like to ask Dr. Latif to walk us through both the clinical case, but walk us through all the case. We will go through all the slides and see this second interesting case that you had for us.
Yeah, Great. Let me take you quickly through this case so we have a little bit more time for discussion. So this is another patient with diabetes, 64-year-old male, effort-induced angina. He's got well-controlled diabetes and hypertension. We in the United States use a lot what are called the appropriate use criteria. So we'll try and use multiple anginals to try and control the patient's angina. And if we can't, we'll then consider them for PCI. This patient actually had multivessel PCI. A year that we'd already treated the LAD and put 2 stents in the LAD. And there was this large, I guess you could call it a ramus branch or first marginal. It looks more like a first marginal, but that looked like it was supplying, that whole territory over there. So if you look between the circumflex and the LAD, there's a whole gap of myocardium where there's no vessels except for this vessel here, which when you first look at it, Tejan, you go, well, let's just treat this medically. This is such a small vessel. I mean, why even bother, with trying to do PCI on a vessel like this? But, when we looked at this, the patient still had angina after treating his LAD. And like I say, to me, if you look at it, I thought these were underperfused, diffusely diseased vessels, and that was maybe subtotally occluded proximally. And I couldn't find any other vessels supplying that territory. So we decided to perform PCI on this, and especially because you see there are 2 branches. So we wired both branches. We then did POBA with initially just 2 O balloons on both branches, and then actually almost did a kiss of the 2 branches. After the POBA, here you see the angio on the left, kind of looks okay. Doesn't look fantastic, but I don't see any flow limiting dissection. I don't see any staining. So we went ahead and treated each branch with a 2.25 by 30 balloon. So first the upper branch, then the lower branch. Okay, next slide. And this was the final result. Okay, there's better flow distally. There's no staining. There's no, flow limiting dissection. But it's not a result that many of my younger colleagues would say, wow, that's such a great result. It looks still slightly suboptimal, particularly the upper branch. But one of the things we've learned with this diffuse disease cases is that you sometimes just have to give the artery time to heal and time to positively remodel. So we left it alone. We didn't do anything further. And as you see, the drug-coated balloon was the last thing we did. So as you said, Dejan, and part of the teaching, you don't go after the drug-coated balloon and dilate again, right? It's the last thing you do before you're ending the case. So that's how we left it. Now let's go and see what the patient's follow-up looks like. So here's 2 months on the left. Look how now these vessels have pumped up from, number 1, I think, increased flow. Okay, that's going down the vessel. But look on the right at 11 months. I mean, the vessel diameters have really improved. And these vessels have healed, and I think there's positive remodeling. These are much bigger than what it looked like at baseline. And if you go to the next slide, I've put them all on one slide to try and convince you that in diffuse disease, okay, you can really be impactful with drug-coated balloons. This was just to convince everybody that I didn't use Photoshop in this case. This was really this patient and what happened. But you really look in the top left and look at how small those vessels were. And look at after 11 months. I mean, and look at how large this territory is. So, for, some of us looked at that vessel in the beginning and said, maybe we should just leave it alone. Give the patient more anti-anginals. But if you look at that at the bottom right picture, you'd say, wow, that's a big vessel, right? It divides into 2. Each branch is more than 2.5 millimeters. That's an important vessel, but we may have overlooked it at the beginning and not completely revascularized this patient.
Azim, just 2 quick questions from the chat box that are really practical. So the first one is, when you're applying DCBs, what are the landing zones that you aim at? And the second is, what is the pressure that you inflate the balloon to?
Okay. These are both great questions. And I want to reiterate something that we glossed over in the graph you showed. When you're thinking about using a drug-coated balloon, it's the last thing I do when I'm treating that vessel. Okay, so I always think of I only open up the drug-coated balloon after I've done all my lesion preparation, I've done my imaging or physiology to tell me that I've got a good result in that vessel, and angiographically it looks good. That's when I say, okay, give me a drug-coated balloon. And all I'm using the drug-coated balloon for is to deliver drug. Okay, I'm not using it to dilate. I'm not using it to post-dilate. I'm using it to deliver drug. So I tend to use longer balloons. I want to go from healthy to healthy. I'm not concerned about putting drug and ballooning in a healthy area that I've not dilated before. So I will cover the entire area lesion plus extend at least 2.5 millimeters on either side of the lesion that I was treating. And I only go to nominal because all I'm trying to do is get full uniform balloon inflation so that I can deliver drug to the wall. Okay, I don't go to 14, 16 atmospheres. I just go to nominal, and you just look at what nominal for that balloon is. It may be 6 atmospheres, it may be 8, it may be 10. And then I leave it for as long as I can. Usually 30 seconds with modern drug-coated balloons are enough, but I will try to get to a minute, even a minute and a half. And it goes to not just something special about the drug-coated balloon, but how to do good old-fashioned POVA, right? So one of the things you young guys need to learn, because I kind of feel older already, is you need to learn how to do proper POVA, okay? And I asked Dr. Colombo to teach me how to do proper POVA. And proper POVA means using longer balloons than you would normally use, non-compliant balloons, okay, matched 1-to-1 to the vessel, and leave them for long inflations.
I think that's really convincing because it's a quite a kind of magic, the positive remodeling that you had at 1 year follow-up. It's really amazing. And I think that, as you said, it's the last thing, the DCB that I do in my PCI. It means that we really have to trust in the drug delivered, because angiographically at the beginning we don't have the idea of a really good result, but follow-up, it's really amazing the result that we can achieve. So I think that we really have to consider the DCB a tool, an important tool in patients like yours, where you had stable angina, but recurrent angina even after treating a larger vessel as the LAD. So I think that this was the real symptom that guided you in this PCI. I mean, you did perform any echo or any stress echo in order to guide, or it was just a symptom that guided you in order to choose to treat a very small vessel?
It was predominantly the symptoms. Before doing this patient's first PCI on the LAD, he did have a positive non-invasive test, stress test. And we treated the LAD and, we said to him, listen, let's see how you do. But he was still symptomatic. Okay, so we brought him back then to treat that branch. And I'm really glad, because a lot of my colleagues, when I told them I was bringing back to treat their branch, I said, but come on, why are you wasting your time? Just give him more anti-anginals. But when you look at that vessel now, okay, and if that vessel now has a small stenosis proximally, I think all of us would want to treat it because it looks like such a good vessel.
Absolutely.
Agree. So before we wrap up this final segment, there are many questions related to bifurcation PCI with DCB, and we will have now 5 minutes to discuss that. Before we move on to that, one final question related to calcified lesions and the DCB coming from the chat box. Dr. Cruz is asking the question. So his question is the following. If we want to avoid stent under expansion in lesions that look to us to be not dilatable enough, should we in those lesions use DCBs regardless of the diameter of the vessel, of course?
Yeah, that's a great question. And it's not an easy question to answer. So I'm going to answer in 2 parts. So the one is, I think we should always try and get good dilatation, even for DCBs, right? In the sense that DCBs work better if you have less residual stenosis. So if you have an undilatable lesion, I think, try other technologies, whether, bring the patient back if you're worried at that time, with another colleague who's more senior, try to do intravascular lithotripsy or atherectomy. There are some cases, though, where because of different reasons, tortuosity in the vessel, the patient's age, you decide, you don't want to be more aggressive because you're concerned about rupturing the vessel. I think in that case, and those are very uncommon cases, they're quite rare cases, I think putting a DCB at the end is better than doing nothing. Okay, probably will give you a slightly better long-term result than doing nothing and just leaving it with a pulver-like result. I think giving the drug will help, but try as much as possible not to get yourself in a situation where you leave an undilatable lesion, just even with drug-coated balloons, because the risk of restenosis is going to be higher.
Okay, thank you. Let us move on then to the last segment regarding bifurcation PCI in small vessels or in larger vessels, but using the DCB. And these are going to be the slides referring to that. So basically, the three main messages that at least I derived from the talk of an experience of Dr. Latib is that we could use DCBs to reduce the stent length, and that what we can expect is positive remodeling effect, which Chiara was also highlighting that we have seen in these cases, which is something that gives us hope that without putting a metal into the patient, we could have satisfactory, more than satisfactory results in the follow-up. So can we use that knowledge for bifurcation PCI is the question of many participants and viewers in the chat box. And there are two principal ways that there are many ways or many combinations how we can use DCBs, but there are two principal general ways to use a DCB in a bifurcation PCI. The first is this one, to use it for the side branch after putting the stent into the main vessel. Now the question is here, and this will be the question for Dr. Latib, after or before? Because if you put the main vessel stent first, then you risk going through the struts with the DCB, which may, of course, damage the drug or take away the drug that you want delivered to the vessel wall. So that is the first question related to this slide. If we use it for the side branch, when to use it? In my opinion, probably before we put the main vessel stent, which is opposite to what we know from crossover stenting in bifurcation PCI. And the second way to do it is what Dr. Latib just did. So use both balloons, both DCBs, and treat the bifurcation just like he did in the previous case, only with DCBs. The problem that I see here, and this is the second question for Dr. Latib, is how do we adjust for the differences in diameters? In larger bifurcations, we are going to have a big step down in diameter going from proximal to the distal main vessel. And as you can see here in those slides, you will have some of the drug washing off distally and maybe even risking a slow flow with some of the DCB. So how do we account for that? So these are the two questions regarding the bifurcation PCI with the DCBs. We have 3 more minutes left. And this is just to show that what Dr. Latib said, we have an independent report here, not from him, also demonstrating the positive remodeling that he showed, this time with intercoronary imaging, and not only in the main vessel, but also at the ostium, at the place of the ostium of the side branch, as you can see on the OCT images here. So Dr. Latib, what do you say to the 2 questions?
Okay, I'm going to try to be very brief. So when thinking about a provisional approach, I like the combination of a DCB. However, I'm a big fan of using it after putting the main branch stent in and doing kissing inflation, okay? And the reason being is because we know that when you put your main branch stent in, okay, you can sometimes get carina shift or plaque shift. If you've already given your drug-coated balloon, you now need to go into the side branch, you need to do a kissing, and you do what you said earlier, Dejan, you disrupt some of the drug that you had at the beginning. So I do provisional stent, I do my kiss. If the side branch looks like it needs something, if it looks great, I don't do anything, I'm done. If there's some suboptimal result and I want to avoid a stent, I just put my, my drug-coated balloon. When doing a whole bifurcation with 2 balloons without stents, I only do that rarely in, like the case I showed you, where it's diffuse disease. And so that mismatch in diameter in the main branch isn't that important. If it is important and I'm worried about it, what I do is I do kissing drug-coated balloons. So I will bring both drug-coated balloons back into the main branch and I'll kiss them. That way I overcome that mismatch in diameter. The last thing I will say is that I use a lot of imaging. It's not by any chance that behind me you see IVUS and OCT, because at Monty, here at my hospital, since I've come, we've made imaging a part of our practice. So we do intracoronary imaging in 80% of our cases here, which is unusual for, I think, the United States and even Europe for many centers.
Thank you very much, Dr. Lateeb. So let us go back to the slides, the last two slides. First is the summary of the second case. So what is the decision-making that brought us here? I think what we have discussed. If we want to use a DCB-only strategy, it needs to be optimally applied, as Dr. Lateeb described. And if we want to do bifurcation PCI with DCB, I think this is more than a resolved topic, and a caution should be there what we do and how we go in a step-by-step manner to both respect the technology of DCB, but also the underlying fractal nature of the coronary bifurcation anatomy. So, Chiara, when wrapping up two cases, what would you say?
Well, I think that this was two amazing cases, and for both, we can say that the most difficult thing is to choose for the PCI. But when we choose for the PCI, because we know that we have some data that discourage us from performing, but when we choose for it, we have to perform it at the best way we can. And today, we know that we can use absolutely drug-eluting stent, but in diffuse disease, in diabetic patient, and in the vessel where we don't want to put a stent, we have some tools like the drug-coating balloon that can absolutely help us. And in both cases, we saw an amazing positive remodeling after the use of DCB. So we can really choose a combined strategy with drug-eluting stent and the balloon, or in small vessel where anyone will put the stent, but maybe anyone will perform the PCI. We can do this with a correct use of drug-coating balloons. So really thank you to Dr. Lateeb for these amazing cases, for this instructional webinar, and for the presentation of his skills. Really, thank you.
Yes, thank you. Thank you to all the participants. Thank you for many questions in the chat box. The ones that we did not answer, we will come to afterwards. And also thank you for the support to PCR Online and Concept Medical. Thank you very much, and see you again next month on the September 30th. We are going to Belgium, to Aalst with Professor Babato. So see you.
Thank you. Thanks for joining us in New York. Bye-bye.
Bye. Thank you.
Thank you. Bye.
Bye. Thank you very much.